Hi everyone, welcome to another Monty Hart lecture. It's a real honor to have today a great friend and colleague, Dr. Aldo Schenone, who will be speaking about hypertrophic cardiomyopathy roadmap from suspicion to diagnosis and referral for specialized care. It's a real pleasure to introduce him today. Dr. Schenone graduated summa cum laude with his medical degree from the University of Carabobo in Venezuela. He then completed his internal medicine residency in the scholar track at the Cleveland Clinic, where he also served as chief medical resident. His cardiovascular medicine training was also completed at the Cleveland Clinic, where he received the Griffin Award for Clinical Excellence and the Irving Dawson Memorial Award. During this time, he served as a clinical instructor for the Cleveland Clinic Lerner College of Medicine and as an associate editor for the Cleveland Clinic Journal of Medicine. He then completed specialized training in advanced cardiovascular imaging at Brigham and Women's Hospital from Harvard Medical School, where he served as a chief imaging fellow. His research interests focus on exploring the impact of multimodality imaging on the prognosis and management of cardiovascular conditions. He has presented his research at numerous national and international scientific meetings, and his work has been published in many peer-reviewed journals, some of those that I had the pleasure to be a co-author in. So thank you so much for taking the time, and we're looking forward to your lecture.
Thank you. Thank you, first of all, for the invitation to participate in this amazing lecture series, which is, I have to be transparent. I was actually listening to this even before I joined Montefiore. Quite a remarkable roster of speakers. So it's truly an honor for me to speak here. So today, I just want to spend about 45 minutes to discuss, could it be hypertrophic cardiomyopathy? And we're going to go through kind of a little bit of the roadmap from suspicion to diagnosis and when to refer for specialized care and why is that important. So these are some of my disclosures. So this is the point that I hope that at the end of this lecture, each one of you can or be able to do based on the presentation today. Define hypertrophic cardiomyopathy and its complex pathophysiology, something that sometimes is dismissed a little bit. Able to apply guidelines-based imaging criteria to diagnose and characterize hypertrophic cardiomyopathy. Importantly, mitigate some of the common errors in imaging to prevent misdiagnosis, which is quite prevalent. Differentiate and beware of the mimickers that can present as hypertrophic cardiomyopathy. Determine the appropriate criteria to refer a patient to specialized care, and execute efficient referrals within the institutional pathway. This is more for the Montefiore system, and outline the importance of a collaborative role within a multidisciplinary care team in hypertrophic cardiomyopathy, and how can that kind of interplay with the rest of the teams. So the first question is why hypertrophic is so important, and first of all, this is one of the most common inherited heart diseases, and the prevalence is about 1 in 200 to 1 in 500. So there is about 20 million cases around the world. Only in the US, there's about 750,000 cases. But the problem is not that it's very prevalent, but also that the majority of patients are out there being unidentified. So we only, at this point in time, only about 10% of the patients with the condition are being diagnosed and treated. So the vast majority of patients are out there without treatment. So then there's a high burden of unrecognized disease that is untreated. And why is this important? It's because if you look at this graph, that was published already kind of from data from some time ago already. If you focus your attention here in the yellow bars, you can see that that's the HCM related mortality divided by age, whether you're less than 29 years old, 30 to 59, or more than 60. As you can see, that mortality in the current era is very similar and comparable to the mortality in the general US population. If you compare that to historical controls, when we were not doing that great in hypertrophic cardiomyopathy, the mortality was was higher. So what this tells us is that if we recognize patients promptly and we treat them accordingly to current standards, this is a treatable condition that is compatible with a normal life expectancy. So that becomes way more important that 90% of patients that remain non-diagnosed, we have to do every effort to identify them and provide them with access to care so that way they enjoy the benefit of the current management. So then we have a lot of work to do. And I think, we need to make sure that we enhance the detection of hypertrophic cardiomyopathy. And I think, in my opinion, that's where the money is. But not only detection, I think we need to really create or improve access to specialized care. And then along the way, I mean, we have come a long way, even in, within my short span of training and now practice. I mean, great therapies are coming down the pipeline, and we already, have kind of commercially approved medications to treat this condition. But we should continue to develop, therapies that are kind of targeted to the specific pathophysiology of hypertrophic cardiomyopathy. What I want to focus today on is to kind of really hit a lot on how we can enhance detection, how we can misdiagnosis, how we can avoid missing the diagnosis of hypertrophic cardiomyopathy, and how can we improve access, and what are we doing here within the Montefiore system. So what is hypertrophic cardiomyopathy? I think it's important to start with the definition. And that's something that most of us know, and it's kind of quite simple, right? So the hypertrophic cardiomyopathy is a condition that is expression is confined to the heart. So already that if anything that is you encounter a patient that has a thick heart, but is experiencing some other manifestation, whether it's in the muscle, maybe it's in the brain, you have kind of cognitive disorders, vision loss or something. Now we're talking about more of a syndromic presentation. So that's not what we're talking about here. So hypertrophic cardiomyopathy, the expression is confined to the heart. I mean, of course, it's characterized by hypertrophy, but one important caveat here is to mention that it has to be in the absence or out of proportion of another cause. And that's where kind of the challenges in diagnosis are usually present in clinical practice, because we see a lot of patients that might have other situations like hypertension that could potentially in some degree explain the hypertrophy, but maybe not all. So then maybe you're in a situation where you're in a mixed scenario where you might have hypertension and hypertrophic cardiomyopathy. And often, but not always, this condition is accompanied by a sarcomere mutation, which is about 30 to 40% of the cases. And then every year that passes, we identify new variants that can increase the yield of genetic testing. So what's the morphologic criteria? And I think that's something that is something that I really want to talk about today. So as you see on the left of the screen, you see the guideline supported criteria, which is any wall thickness industrially, of course, that is equal or more than 50 millimeter anywhere in the ventricle. That is not explained by another condition. Or if you have a 13 to 14 millimeters in the setting of a positive pathogenic genetic variant, or you have relative patients with a known history of hypertrophic cardiomyopathy. So this is kind of what we define now as a fixed criteria. And that's something that is a moving target. There's a lot of effort right now on the field to try to determine if we need to actually do a demographically adjusted cutoff, right? It's not the same my heart to the heart of, say, Shaquille O'Neal. So I think there's going to be big differences in terms of what you can expect and the degree of hypertrophy you might encounter in both of us. So there's a lot of effort into kind of making that more individualized. There's some data out there, but this is more coming. The other thing that I think it deserves the attention is that, within the hypertrophic cardiomyopathy, the apical is one that can sometimes be easily missed. It's because it's very hard for the apex, which is usually very thin under normal conditions, to thicken all the way to make it to the 50 millimeter criteria. So many times we don't meet the criteria, and these patients can get, or can be missed in the diagnosis. So that's why a lot of effort has been done, especially for a group from the UK, to try to apply this kind of index apical wall thickness. We're going to talk more about this, but by doing that, we're more likely to identify these patients. The other thing is that it's not only about the criteria that we're applying, and as you see here, I'm calling these not diagnostic criteria. I'm calling these morphologic criteria because some of these findings might not be pathognomonic, as we're going to see in a little bit. But you can find other supporting findings that can increase your certainty that maybe you're in fact in the presence of hypertrophic cardiomyopathy, the presence of the thickening in the septum, like presence of SAM and LVOT obstruction, the presence of apical displaced papillary muscles, or the presence of elongated mitral valve leaflets or mitral valve abnormalities. So this is what is presented, and we're gonna go dwell a little deeper in a little bit into kind of what are the pitfalls and that we need to be aware. So let's go here, and this is something that I encounter, even though it's kind of more on the practical perspective, but it's something that I encounter a lot in practice. So this is a patient, and always cases are the best way to learn something. So this is a 45-year-old female who presented with a syncopal episode. You went through the evaluation and there's not much, no history in the family, no history on her personal history. And then you get an echo, and this is what the echo looks like. And then you get, for whatever reason, there's two measurements in your echo report, and you're trying to determine is whether this patient, meets criteria, morphologic criteria for hypertrophic cardiomyopathy. So I guess what I'm asking here is, what is the correct measurement? And in here, in this particular, you have one that is 18 that would meet criteria. The other one is 12, not quite meet the criteria. So in this particular case, the patient does not meet criteria. And why does it meet criteria? Because the correct measurement is the one that you see in green. And what you're seeing in the red is basically we're including the RV trabecula. And the RV trabecula should be excluded because we can, not only create the, beat the criteria for, for no reason, but also can be quite significant in patients that actually have hypertrophic cardiomyopathy, and we can make it to the threshold where ICD can be required. So we have to be very careful to make these measurements properly, make sure that we take the time to identify the compacted myocardium. Sometimes, and I usually advocate that, these measurements should be correlated to the short axis as we did here, and you can see a little bit better that compacted myocardium. Make sure that you're not getting an oblique cut. And this here in MRI, you can see how if you rely only in the parasternal long axis, how can you have errors in your measurement? If you focus your attention in the bottom picture to the right, if you see the far right, you can see that the red line here in the parasternal long axis on MRI, and you try to look how that measurement looks on the short axis on the left. You see that that's an oblique cut. So actually, you're overestimating the measurement if you take that parasternal long axis. So that's why it's very important that we always correlate with a short axis measurement. So that way you get the actual measurement for these patients. So this is, again, talking about a little bit about the measurement. This is another patient that I want to present to you where, a 50-year-old male comes with, history of hypertension and comes with chest pain and has this kind of very abnormal ECG. There was some concern for like a obstructive CAD and a acute coronary syndrome. So a coronary CA was obtained, which was negative, was excluded in obstructive disease. Just because there was concern for cardiomyopathy, the patient got an MRI. And the question that I have for you here is, what would be the next best step in managing for this patient after looking at the MRI pictures? You give reassurance. You say, oh, this is nothing. Looks pretty good. All the walls looks fine. You see the LDG images at the bottom. There's no LGE to suspect Minoca or anything like that. You think that coronary CTA is not that good. You want to go with left heart cath, or you have some suspicion here, and you want to say, I think I really want to get family history in this case. So the actual answer here is assess family history, and the reason why, if you pay close attention to the wall thickness, as you go from the base to the apex, if you focus your attention on the left side of the screen, that 7 millimeters becomes 10. So there is a lack of taper of the myocardium. So normally myocardium should taper as you go from the base to the apex and become thinner and thinner and thinner. In this case, we don't see that. What we actually see is that it gets a little bit thicker. It doesn't quite meet the 15 millimeters criteria, but it quite has the lack of that kind of tapering. So this is what is called relative variant of apical hypertrophic cardiomyopathy. So this is kind of what I was mentioning in the kind of emerging criteria that, with data from the UK group, they recognize that the 1.5 centimeter is lack sensitivity in apical. And if you do a kind of an index criteria, and you get a number that is anything between 5.2 to 5.6, your sensitivity and accuracy to detect hypertrophic cardiomyopathy increases from 69 to 92. And if you're in presence of a relative apical hypertrophic cardiomyopathy, as the case that I presented to you, you go from 17 to 94, 95. But what is more important is, I think, is in this graph to the right. When you are looking in a case with potential, apical, I think what you want to look is incorporate ECG. If you have typical ECG, you need to increase your suspicion. Then when you look at your images, you want to be looking for that lack of tapering on the myocardial thickness. Sometimes you might see your log, you see a little bit of an apical aneurysm, and that might be kind of the other clue that you are in presence of hypertrophic cardiomyopathy. And I can guarantee you that you're going to be picking a lot more apical hypertrophic cardiomyopathy if you just apply the fixed criteria. One thing that I want to really hit here during this lecture is that there's a lot of focus on hypertrophic cardiomyopathy from a perspective of hypertrophy, and this is just the tip of the iceberg. So hypertrophic cardiomyopathy has way more than that. The first thing is just there's sarcomere mutation that can lead to exaggerated force generation. We're gonna see how that is important. You get compromised LV mechanics, and you end up with normal systolic and diastolic function. You get altered myocardial energetics and myocardial dysfunction. You get abnormal myocardial perfusion and microvascular dysfunction. You get abnormalities in the mitral valve apparatus, and of course, LVOT obstruction, as we all know. But also we get a wide variety of fibrosis that include replacement, but also interstitial fibrosis. And some of these other elements are something that many times we don't pay too much of attention to. So let me start with explaining a little bit of how the sarcomere works, and then what are the abnormalities you can encounter in these patients. So if you pay attention to this cartoon, we can see here, if you go back to medical school, we see that the red, we have the actin, and in green, we have the myosin. And then they get together, they get activated, you get the contraction. One thing that you're gonna see here is that some of them are engaging in the contraction, but many others are in the background, just in a resting state. So this is a normal kind of way of looking at a sarcomere. So now let's move on and see what happened in hypertrophic cardiomyopathy. When in hypertrophic cardiomyopathy, what happened is that you increase your horsepower. Instead of having just 6 myosin heads binding, you're gonna get doubled. You're gonna get way more of that. So you're gonna have more myosins in the active state engaging in that contraction. So you get more horsepower, but you're gonna need to use more energy to really support that contraction. You end up with an exaggerated force generation, something that you don't need that much of energy, that much of force. You spend too much energy. And of course, as you run out of energy, you're gonna start getting impaired relaxation and diastolic dysfunction. So that's the fundamental pathophysiology that we encounter in hypertrophic cardiomyopathy. So what's the problem? The problem is this. If you see here on the left, this is a normal a myocardium in a normal individual. So all the fibers are aligned perfectly to each other. So they add to each other. So even if you don't have that many myosins, you can really sum up the contraction. But look on the right. This is what a hypertrophic cardiomyopathy looks like. So everything is going in a disarray. So what you're going to see is that some fibers, even though they're hypercontractile, they're going to be fighting against others, and they're going to be canceling each other, which really alters the contraction and the mechanics, rendering the ventricle dysfunctional. So you can see here that if you look at the GLS, the global longitudinal strain, which is a more sensitive marker of systolic function, you can see that although many of these patients have a normal or increased LV ejection fraction, you're going to see that individuals with hypertrophic cardiomyopathy and hypertrophy has a much reduced LV strain compared to normal individuals. Even in individuals that has only gene positive, but yet not phenotype, they're still beginning to experience a little bit of decrease in that GLS. So then this is a situation where you have a paradoxical systolic dysfunction despite having a normal or an increased ejection fraction. And that can carry on or cause symptoms. Even if you look at the ventricle and all the dynamics of the ventricles, what they do in all the different dimensions, you see that every single one of them is abnormal in hypertrophic cardiomyopathy. Not only in sometimes like in GLS is reduced, in something like the basal rotation or the twist, it actually goes in the opposite direction. Again, promoting that kind of systolic inefficiencies that we just mentioned. One element that I want to touch upon within the diagnosis and the concepts and the pathophysiology of hypertrophic cardiomyopathy is the idea of obstruction in hypertrophic cardiomyopathy beyond the age. If you look at your left, this is a traditional mechanism that we all learn for hypertrophic cardiomyopathy. You get a hypertrophic septum, and you get your elongated leaflets that gets pushed or pulled into the LVOT, and that's what causes the obstruction. So in many patients, that's what we see, but in many others, we see that in addition or alone, we can see abnormalities in the mitral valve apparatus that by itself can cause obstruction. So you can get these apical displaced PAPs, or there are hypertrophy or two lags. The mitral valve is too elongated and kind of sails and engage into the LVOT, waiting to be pushed, or the chordal attachment is actually abnormal. All what it causes is that instead of the mitral valve closing posteriorly away from the LVOT, it closes anteriorly and in the way of the LVOT, promoting LVOT obstruction. And that's kind of important because many times there's no need to do a myomectomy because there's no thickness enough to do that. But we have to be careful about identifying these elements in the mitral valve apparatus so we can fix it if we're going to go for surgery. So the other thing is the mitral valve apparatus might also lead to primary MR in addition to some related MR, and you need to be very careful where you're characterizing and identifying your patient with hypertrophic cardiomyopathy. So the other thing that I think is important is that not only these hearts are using a lot of fuel, a lot of energy, but they get impaired myocardial perfusion. They get impaired production of energy. They get coronary remodeling. They get capillary rarefaction. They get also myocardial bridging in some of them. That along with very prevalent microvascular dysfunction make them less likely to produce the amount of energy that they need. So usually you get this kind of chronic state of ischemia due to an altered supply and demand, plus the abnormalities in the mitochondrial abnormalities. So all that leads to these kind of chronic stiffness in the heart that leads to diastolic dysfunction, and that's going to be something important for us to identify. So those are kind of some of the more like novel or kind of more deep pathophysiology mechanisms that I think is important that it's important to know because it can carry on important implications when we deal with these patients. So now moving targets a little bit to diagnosis, I just want to emphasize first that, hypertrophic cardiomyopathy is first and foremost a clinical diagnosis. And I cannot emphasize that enough. So hypertrophic cardiomyopathy is not an imaging diagnosis, okay? Imaging is central, and we're going to talk about that in a little bit. But you got to go to your process. You got to get your family history, 3 generations, to see if anyone has history of something like hypertrophic cardiomyopathy. You want to understand the clinical presentation. Yes, you want to use multimodality imaging to really narrow and try to secure that diagnosis. And genetic testing is usually useful even for diagnosis. Usually genetic testing, we use it for screening in the family. But many times when we get this kind of diagnostic dilemma where is this something like is more hypertension, is hypertrophic cardiomyopathy, is a mix, whether we have some sort of like an infiltrative cardiomyopathy like Fabry's disease mimicking. So I think genetic testing, for the sarcomere, but also extended genetic testing can be quite helpful in trying to kind of really secure the diagnosis in very challenging cases. So the take-home point from this is that it's just not identifying that thickness. Even if you're careful about the measurement, I think it's important that you exclude things that can mimic, hypertrophic cardiomyopathy. So how imaging plays a role in the diagnosis. So the way I see it is that, it's really an expanded role. We have the way I divide this into phase 1 and phase 2. Phase 1 is, it aids in the diagnosis. Again, it doesn't make the diagnosis. It aids in the diagnosis. At the end of the day, you're going to need to integrate the findings with the clinical presentation to make the diagnosis. And imaging is quite helpful in excluding phenocopy. Once you make the diagnosis, you go to phase 2, because the job of imaging hasn't finished just because you make the diagnosis. You really want to phenotype, characterize, recertify your patient, and identify if a patient has symptoms, what is the mechanism or the mechanisms that is accounting for the symptoms? Because many, patients might have the same symptom, but that can come from different mechanisms like MR, diastolic dysfunction, LVOT obstruction, as we're going to see in a little bit. So it's important to really narrow down to what's the first or the predominant mechanism of symptoms. And finally, there's some idea of like really assessing response to therapy, especially with the novel therapies that we have available right now. So the imaging is really comprehensive in the way it can provide us, a lot of information. So we can identify not only if we meet the morphology criteria, but what's the morphology, what the phenotype we have. It can really help identify much of our abnormalities. You can see here with the echo. Not only identify but measure LVOT obstruction, identify systolic dysfunction not only with EF but with strain. We can identify myocardial ischemia, microvascular dysfunction with nuclear techniques, identify apical aneurysm, which is going to be very important for recertification, detect and quantify myocardial fibrosis, and also identify diastolic dysfunction. Each of these targets for imaging can be the reason or a mechanism for someone to have either a clinical presentation or a symptom. So it's important that we really do a comprehensive assessment of these patients. So what does the guidelines say about the imaging and what are the indications? I think first echo, should be done as we all suspect and know. In anyone you're suspecting or that has hypertrophic cardiomyopathy, to really identify the wall thickness, but also to identify LVOT obstruction. So the number that we're trying to identify is an LVOT obstruction that is more than 50. So even if you see obstruction with 30 millimeters of mercury, you still need to do provocative maneuver, or if you don't do it with provocative maneuver Valsalva, you have to go with do exercise. Because the threshold that you're trying to identify where the patient is going to benefit the most from LVOT reducing therapies is 50 millimeters of mercury. If you having a case of apical, or you're concerning about apical aneurysm or atypical patterns of hypertrophy, you should be using contrast because your capacity to detect this is enhanced. What about MRI? Well, MRI, I can tell you that my perspective on this is that virtually all patients benefit from an MRI. So what the guideline says is that if the echo is inconclusive, if you are suspicious for mimickers, if you are still unsure about the ICD decision, you can use MRI to identify the burden of gadolinium, which is a replacement fibrosis, and help you in that. Or if the mechanism of obstruction is inconclusive on echo. If you do this enough, you're going to realize that most patients are going to fall in at least one of these categories. I mean, the only patient that I can think of that maybe you don't need to go the route of MRI is someone who is a family member of someone who has genotype positive hypertrophic cardiomyopathy. That patient has genotype positive and finding consistent with hypertrophic cardiomyopathy in an echo. And by the way, the family member or someone in family member died from sudden death. So that patient, you already have your diagnosis with echo. But outside that, I think, all the patients would probably benefit from an MRI. So when should we be using cardiac CT? I think cardiac CT can be used as an alternative to MRI and on echo when you still have questions about the diagnosis. We can measure the wall thickness pretty good on CT. We can also do something that is called lay iodine enhancement, where you can actually see or kind of try to identify the presence of fibrosis with, similar to what you do with LGE. And it's kind of the gold standard, I would say, for the exclusion of obstructive CAD, especially on the epicardial vessels. On the other side, I think nuclear, particularly PET, can be quite useful when you see a patient that comes in with symptoms that sounds anginal. You went through your evaluation. There's no LVOT obstruction. There's no obstructive CAD on a CT, but you're still thinking that this could be microvascular angina. And I think PET can be quite useful in this patient, and that's something that is quite prevalent in this patient population. So what are the main imaging features of hypertrophic cardiomyopathy? Well, we talk about it. Asymmetric hypertrophy. You can have any flavor you want. The most one or the typical ones that have been described is the D shape you see here on the left, the sigmoid on the right, and the apical at the bottom. But you can have hypertrophy anywhere in the ventricle. In fact, sometimes can be affecting one or two segments. So that's why MRI can be quite useful, because echo can miss those cases where you have very, very localized, thickness. You're going to see patients with, some, of course, in LVOT obstruction. Actually, it's up to 70% of patients can have that. And then, of course, the typical, patchy fibrosis. But even if you see some of these, findings, I think just looking at these findings in isolation should not be diagnostic. I mean, this is not pathognomonic. You still need to go back and understand, does this patient have syndromic features that can make this patient have something else as opposed to hypertrophic cardiomyopathy. So you always have to go back and integrate with the clinical picture. So again, imaging is not just purely diagnostic, it's not pathognomonic. You have to integrate. So these features in isolation, as I said, do not secure the diagnosis. You have to integrate and make diagnose, as a clinical diagnosis. So, what this leads me is to kind of a case that I think kind of really highlights why this is important. So this is a 67-year-old male who has history of hypertension and CKD, who was reportedly, who was reported to have hypertrophic cardiomyopathy and came to us for evaluation of dyspnea. So these are the echoes. It quite meets the criteria on the septum. It's 23 millimeters. The F is a little bit low, which is kind of a little weird for hypertrophic cardiomyopathy. Only about 10% of cases can get to end-stage heart failure or end-stage cardiomyopathy, so we don't get to see that often. And then we'll see that there's no LVOT obstruction, but the genetic testing that was done before coming to us was positive for the myosin, loci, but was a BUS, was a variance of non-significance. So this patient came to us, and we just kind of evaluate the patient. So the question I have for you is what are the best next step? Do you start a myosin inhibitor? You put an ICD? You obtain an MRI, because no MRI has been obtained, or you proceed with exercise choreography. So I can tell you that in myosin, even if this was a hypertrophic cardiomyopathy with a low EF, that would be contraindicated. I mean, an ICD, if it's truly HCM, but I don't think we're quite sure this is HCM yet. And then exercise at this point, I think before securing the diagnosis, I don't think it's the right answer. So in this case, MRI is the right answer. And in this case, this is what we obtained. This is not hypertrophic cardiomyopathy. This is a case of amyloid that is mimicking as hypertrophic cardiomyopathy. So that kind of really highlights the importance not to just rely on single wall thickness to make the diagnosis, even if you have some of these kind of genetic abnormalities that in this case was actually not a pathogenic, was a BUS. So in this case, a PWS scan was obtained. So this actually was a case of ATTR cardiac amyloidosis. So you have to be very careful about making diagnosis in isolation based on just wall thickness. Why is this important? Because if you look at the evidence, this is the data from the Cleveland Clinic where, out of almost 2,500 patients that were sent for myomectomy for obstructive hypertrophic cardiomyopathy, those people have septal thickening, they have LVOT obstruction, meeting criteria for myomectomy. They were sent for surgery, and when they got back the biopsy, they saw that 1 in 5 had an alternative diagnosis. And the common mimickers to remember are hypertension, Fabry's, and amyloidosis. So just because you have hypertrophy and LVOT obstruction on an echo doesn't mean that patient for sure have hypertrophic cardiomyopathy. I think your MRI and your clinical assessment becomes very, very important. And this is where MRI shines, right? So here are different cases that you can see how hypertrophic cardiomyopathy looks like, with like that focal thickening and patchy LGE, as opposed to, let's say, amyloid, which is more of a diffuse and focal, diffuse subendocardial. We have Fabry, which is the typical LGE in the lateral wall, or Dano's disease, which is thick septum, but the LGE is very extensive, but happen to spare the septum, which is quite of a unique feature of Dano. So MRI can really help you a lot in making sure you exclude mimickers. So CMR is cornerstone in the evaluation of mimickers, as I said. So once you kind of secure the diagnosis and you exclude the cardiomyopathies, you got to get into this in the second phase, which is primarily identifying the mechanisms prognosticating this patient and phenotyping. So we know that all the hypertrophic are not the same. So you have the sigmoid, the reverse, and the apical, and each of them has a different or a potential different clinical presentation. So the sigmoid tend to have more LVOT obstruction, while the reverse tend to be a more LGE and less LVOT obstruction, while the apical tend to have less obstruction, but can have apical aneurysm and more of a diffuse LGE at the apex. The second thing that you need to really look for is the LVOT obstruction, as we mentioned. We know that 2/3 or about 70% of patients with hypertrophic cardiomyopathy have obstruction. So from those who have obstruction, half of them are going to have obstruction at rest, which is defined in a gradient of more than 30. But the other half is going to have obstruction where you actually do Valsalva, or sometimes you have to exercise it. So we have to be on the look for this. Otherwise, we're going to miss half of the patients with obstruction. And remember, the typical threshold that we are trying to identify is the 50 millimeter, which is the threshold that we usually use for therapies, or we think that the patients are going to benefit the most from therapies, even though sometimes we start with lower gradients. So let's go back to another case, because I really want to highlight the importance of this. So this is a 48-year-old male with history of hypertrophic cardiomyopathy who comes in with dyspnea on exertion. So the patient comes and gets an echo. The septum is 50 millimeters, which is meeting the criteria. He knows that has that. So we get in and do an LVOT on the right through the LVOT, and you can see that you quite not meet criteria for obstruction. You get in only 22 millimeters of mercury. So the question in this case, and you see that the patient has a little bit of SAM on the echo on the left, is just almost touching the septum. So you might be worried that maybe there's more we're missing here. So in that case, the question is, what should we do next? Should we just evaluate for non-cardiac dyspnea because the patient doesn't have obstruction? We should repeat the gradient with prelude reducing maneuvers. We should start myosin inhibitors, or we should start metoprolol. Well, in this case, the right answer here is to repeat the gradient with prelude reducing maneuvers, and namely Valsalva. Okay, and this is a real case. In this case, came to us. We did, we of course did Valsalva, and you can see that now we identify an LVOT obstruction up to 53 millimeters of mercury. So now we identify why this patient is out of breath. If you were to be seeing this patient, and the patient, let's say, make an LVOT gradient of, let's say, 45, in that case, you would, even though you identify LVOT obstruction, you would really want to proceed with the exercise stress to really see what the maximum LVOT gradient is in this patient. Because as I said, usually the symptoms or the patient tend to benefit the most when the gradient is more than 50 millimeters of mercury. So this is another case that I was just gonna wanna dwell into in case of practical cases in hypertrophic cardiomyopathy. This is a 45-year-old male with again same exertional dyspnea, and you learn the tip from last case, and this case you were very sure that you did rest and Valsalva, but you did not get anything. You get a maximum gradient of 16 millimeters of mercury. But then you say, okay, I think we need to go and do exercise, and you do exercise, and this is what you get. You get this kind of profile, and if you measure like what is kind of the gradient here based on this profile is 100 millimeters of mercury. So based on this finding, what do you do next? Do you do metoprolol? You do myosin inhibitors? You repeat the stress echo because you don't trust the findings, or you reassure the patient that there's nothing to worry about here? Well, if you pay attention to this profile is quite not lay picking. It's a little more rounded. So this is actually a MR signal. So you got to repeat your stress echo or repeat the acquisition if you can to try to kind of clear the MR signal and try to get into the LVOT signal. Okay, so this is important so we don't confuse MR signal for LVOT signal. So the second thing that you need to be thinking is that look at that signal. I think it's a very dense signal of MR. So you have to be thinking, maybe I miss LVOT obstruction, but maybe this patient, at least this MR could be a contributor to the symptoms of this patient. So this is kind of a nice representation in how you can really differentiate LVOT from MR signal. So your LVOT signal tend to be more of a late peaking, a little bit of dagger shape, has a shorter duration than the MR, and it has usually lower velocities than MR. So MR usually gets into the 6 to 7 meters per second. So you can always start with the MR, see what the MR looks like, which again is more rounded, and compare to what you think the LVOT signal is. One trick for imaging acquisition is that, as you can see here on the top, if you go to the right, you see that the line of interrogation is at the LVOT. But if you move more anteriorly, almost kind of getting out of the LVOT, that's where you kind of get your signal here in this particular case. So it's a good practice to start posterior and start moving your line of interrogation a little anteriorly until you see the change in the shape, so you can be really sure that this patient is actually a case of LVOT obstruction and not MR. So we talk about a lot about LVOT obstruction, but I want to remind you that LVOT is not the only mechanism that could cause symptoms in our patients. So we know now the pathophysiology in hypertrophic cardiomyopathy. We know that systolic or diastolic dysfunction can be a cause of symptoms in these patients. We know that mitral regurgitation as a second cause could be a cause of symptoms. And microvascular ischemia, by the way of course, epicardial CAD, but even in the absence of epicardial CAD, microvascular dysfunction, as in this case of apical hypertrophic cardiomyopathy, could be a main source of chest pain or shortness of breath. And of course, arrhythmias, which are not necessarily detected with imaging, but you have to kind of look at these patients as a whole and not just kind of in pockets. So same symptom may arise from different mechanisms. It's for you to determine what's the main symptom, if there are multiple ones, or what's the one that is actually causing symptom in the patient. So this is a little bit about risk stratification. I don't want to go through the entire algorithm. Points I want to highlight here is that, as you see here highlighted in red, these are all the different elements where imaging becomes essential for risk stratification. So once you kind of say that the patient has never had an arrest or a sudden death that was avoided or a sustained BT in the past, you get into kind of the primary prevention category. And we can see how imaging becomes very useful. You look for massive LVH. That's why very important that we measure the wall thickness properly, because we don't want to necessarily overdiagnose, but at the same time, we don't want to send patients for ICD where they don't need it, just because we're measuring beyond the compacted myocardium into the trabecula. You want to look for apical aneurysms and ejection fraction. Of course, LGE becomes very, very important when all this becomes negative. The other thing that I want to highlight that I think is important is that, when you meet the criteria for any of those, the recommendation is to go and do a 5-year risk estimation for shared decision-making. Within that 5-year risk estimation, echo becomes very useful because LV size and LVOT gradient becomes elements of that risk estimation. So imaging is central in the prognostication of this patient. So these are some depictions in cases and how these markers can be helpful. We have a case on the left of sigmoid septum with LV dysfunction. This is end-stage hypertrophic cardiomyopathy that needs an ICD. We have a case of a very massive LV wall thickness, as you can see here. A lot of scar or the presence of an apical aneurysm, as you can see here. So I want to just kind of delve a little deeper into the LGE, because it's usually a common source of error in sending patients from ICD. So this is a 55-year-old male with history of hypertrophic cardiomyopathy who came to you for sudden cardiac death risk estimation. The patient doesn't have any of the criteria, so you end up getting the MRI, and this is the MRI. As you can see in the MRI, you see this kind of really white, hyper-intense area of LGE, but also you see these also more subtle areas of grayish, LGE around it. And you can see that it's just very different compared to the infralateral wall, where there's very black and no LGE there. That's a normal myocardium in the infralateral wall. So you do your, we're in the era of AI. You run your AI, and the AI gives you two possibilities. One possibility is when you include the LGE, not only the bright, but also the more grayish on the left. And if you quantify that, that comes to be 15% of the myocardium, which would meet criteria for an ICD. The other model will give you only the bright and exclude the gray, and that only gives you a burden of 8. So the question is, do you put an ICD in this patient? And the answer you can already saw. The answer is no. Why the answer is no? Well, because the bright LGE is what is replacement fibrosis. So the bright LGE is what it represents cell death and changing of the cells for dense fibrosis, and that's what is linked with sudden death. The more subtle and grayish thing that you're seeing around it, that's what is called interstitial fibrosis. So there is no cell death. It's just basically collagen deposition in between the cells. And then there's not that strong of a link with interstitial fibrosis and sudden death. There's more link with heart failure events. So when you're making decisions on your ICD, you have to be only measuring, quantifying the bright replacement fibrosis, not interstitial fibrosis. Okay, so now moving gears a little bit into referral, and then when to refer a patient to hypertrophic cardiomyopathy clinic. So if you look into the guidelines, the guidelines really open the door to any patient that has hypertrophic should or could be referred to hypertrophic cardiomyopathy clinic. And they venture to say that maybe that can lead to better outcomes. And the way this works is in a co-management. So if this is your patient, you're going to continue to manage your patient, but then you're going to get input from the HCM multidisciplinary team about potential managements. You want to send the patient if you have a challenging diagnosis, so you don't know if this is for sure hypertrophic cardiomyopathy. You want to get help from the clinic. Or if you have difficult treatment decisions. So, of course, cardiac myosin inhibitors, you need to be credentialed for that. So we tend to kind of take that into the clinics, but if you're trying to make a decision between two therapies, they might be kind of reasonable to consider both. If there are nuanced decisions, especially ICD, or if you're thinking about potentially sending patients for, invasive procedures. So those patients needs to be seen within the hypertrophic cardiomyopathy clinic so they can have a multidisciplinary evaluation and a heart team decision. So this is just like a little hint for some of you that are kind of thinking or kind of joining us from Montefiore. So this is actually the referral order that we actually have live, REF 333. If you put that into your order set, that will go directly to the hypertrophic cardiomyopathy clinic referral. So we're happy to see and help you manage these patients. So I just want to kind of get a little bit now and switch gear a little bit on how the hypertrophic cardiomyopathy clinic operates, and why is that important. So the way it works is that you have a core hypertrophic cardiomyopathy program, which is the core team. But that core team really works in close collaboration with multiple services, including the primary or the clinical cardiologist. So many times the clinical cardiologists really handle cardiology and anything that has to do with risk factors, CAD, and so on, while we focus only on the hypertrophic cardiomyopathy recommendations. Many times we get input from cardiogenetics. Sometimes when the patient is kind of deteriorating, we have to kind of get input from advanced heart failure for transplantation. Of course, surgery and interventional when there is need for procedures. EP is a close collaborator in terms of ICD, and of course imaging as we get our diagnosis and risk stratification. And then many of us, not many of us, but just also very often, cardiac rehabilitation becomes an important tool. So this is just going to introduce to you kind of what the Montefiore Einstein team is, and we have Sandhya, Daya, myself, as HCM experts that brings different expertise all the way from heart failure to EP and cardiogenetic and imaging. But actually the foundation of these, which is kind of Raymond J and Daddy, which is really takes the operations of the clinic to the next level, coordinated for the patient. So also I want to shout out to some of the team members of the hypertrophic QI and research team, Ahmed as the research fellow, and some of the general fellows like Christine, Arosh, Sanjana, and Gara has been helping us with some of the projects that we kind of take into fruition very soon. So what are we doing in Montefiore Einstein to kind of really close the gap in in diagnosis? we recognize that we have a lot to offer to these patients, but we recognize that we are not doing a great job in diagnosis, around the world. So what we're doing right now is just we already deploy this QI initiative program as part of the hypertrophic cardiomyopathy program to really enhance the detection of hypertrophic cardiomyopathy within the division and the hospital. So we have incorporated artificial intelligence algorithms that really get input from ECG that is obtained in every clinic to really select or identify or flag individuals that could potentially have hypertrophic cardiomyopathy. And then we take it from there. We actually reach out to the individual providers and offer them a referral to the hypertrophic cardiomyopathy clinic for comprehensive evaluation. But we don't only do that. We also actually work on streamlining all the process of referral to make sure that the process of referral and evaluation is frictionless. So where people can really get access and patient can get access to a specialized care very easy through order sets and care coordination to the team. And finally, we're doing a lot of effort on education. This is one of many of the educational activities that we're doing to increase awareness of hypertrophic cardiomyopathy, or how to best approach and diagnose these patients. That is involving not only us providers, but also some of the folks that coordinates the program and sonographers. And all that will hope that we can really enhance the detection and take that detection rate from 10% to something way higher than that. So with that, I just want to conclude to a few take-home points, and maybe we have a few minutes for discussions. Remember that hypertrophic cardiomyopathy is very prevalent. We have to do a better job in diagnosis, but also that it's just way more than just hypertrophy. It's a complex pathophysiology. So you gotta exclude phenocopy. It's not enough to just make the diagnosis on the basis of a fixed threshold, without having a comprehensive evaluation and clinical integrations. Remember, that septum, you gotta exclude the trabecula. Don't include that because you might make errors in the diagnosis. The fixed threshold, remember, lacks sensitivity, particularly in apical. So you gotta do your adjusted, your body suffers adjusted, or look to that tapering as we discussed. I think that virtually all patients benefit from complementary cardiac MRI, except the situation that I mentioned. Do not settle for LVOT gradient at rest. Do Valsalva, exercise them, and do not confuse MR and LVOT signals. Remember that there are many other mechanisms of symptoms beyond the LVOT obstruction. So remember your systolic, your diastolic dysfunction, your MR, your ischemia due to microvascular disruption. And then work in close relation with your hypertrophic cardiomyopathy center, whether that's local in your institution or regional, you can get access to it. Especially if it's challenging patients, so this patient can get the best that they can get, which is what they deserve. Thank you for your attention, and I'm excited to hear your comments, your questions, and hopefully have a little bit of a discussion. And this is the CME code for those that want to have it.
Thank you so much, Aldo. That was an amazing masterclass on HCM. Congrats on the amazing work you're doing, and we're very lucky to have you and the whole HCM team, at Montefiore. And importantly, I think it's good to emphasize that these services are not only available in the Bronx, but also all through Westchester, where we can do imaging and provide services at White Plains and some of the other hospitals. So please put your questions in the Q&A. I would like to also make an advertisement for next week. We'll have the second part of HCM with Eugene Brownwell, who will be giving us also a lecture on HCM and his perspective. Just to start the questions, I would like to ask you about atrial fibrillation, which is kind of a different thing, right, in HCM with important prognosis. And we saw Dr. Adaya Weisler there that has published in it and is part of your team. What are your thoughts? Should people refer even more if they have atrial fibrillation in their HCM patients?
Yeah, I mean, patients with hypertrophic cardiomyopathy are at an increased risk of atrial fibrillation, and actually atrial fibrillation is quite prevalent in this patient group. So couple of considerations that I want to say. First of all, is that anyone who has hypertrophic cardiomyopathy and atrial fibrillation, you anticoagulate. So you don't go through CHA2DS2-VASc score. This patient had an increased risk of stroke, so we don't follow the CHA2DS2-VASc route. So just anticoagulate them. The second thing is that because of the pathophysiology that we just learned, these people really tolerate very poorly atrial fibrillation. They're already in a state of ischemia. Now you put them to be, a little bit of irregular and kind of maybe faster. So you're going to aggravate that state, and it's going to create a little more of a stiffness. So that can precipitate, heart failure exacerbation and so on. And they can feel that they feel very poorly on AF. So I think rhythm control becomes essential and becomes very important. So in my practice, I think any patient have atrial fibrillation, I tried my best to keep these patients in sinus rhythm, and that's why having a close collaboration with EP becomes very important. Whether you're going to go directly to ablation as the most effective way to maintain sinus rhythm, if you can. Sometimes you have to do both. You have to do ablation and antiarrhythmics, or at the very least try to do antiarrhythmics if you think the patient is not a candidate for ablation. The second part is that if you look back into non-traditional risk markers of sudden death, AFib has been studied, and actually there's a strong link, at least on observational data, between AFib and sudden death. So which really kind of emphasizes the importance of AFib also as a prognostic marker in these patients. We're actually doing some research now and try to get one step ahead. Once you get the patient as an AFib, maybe you already have the risk, especially for sudden death. But then what are the things that we can do to really prevent that from happening? And one of them is, with a long-hanging fruit, is just sleep apnea. We're working now in some data from the National Inpatient Data Set where we're identifying that OSA can be actually linked to sudden death through AFib as a mediator. So maybe we have to be a little more careful about AFib and actually try to identify the risk factors, that OSA is one of them, and try to treat them as a primordial risk factors for sudden death and prevent, of course, these kind of, side events from happening.
Thank you very much. Yeah, I think early identification and part of the work you're doing is leading to that. So some good comments. We have one from Dr. Neches. He asks about the so-called HCM of the elderly, he says. So I'm assuming he's talking about the discrete upper septal thickening. Is this amyloid? Is this HCM? What should we order and how we differentiate it?
Perfect. Yeah, absolutely. I think that the first thing that I would say is that this patient that has like the focal hypertrophy of the elderly, I would not just dismiss every case as such, just because the patient is just 70 or 80. I think you need to kind of really take this seriously and then try to go to your usual evaluation, right? So this patient have hypertension. Does this patient, has any other particular risk factor for, let's say, amyloid, family history? We know that if you look at the data, even though we always kind of get excited and pump about like, how can we prevent sudden death? How we can prevent heart failure? But if you look at the data on hypertrophic cardiomyopathy, the majority of patients with hypertrophic cardiomyopathy have a normal life. So they have never have symptoms. They never have any event. They actually die from something else and never had anything. So if that's the patient that you're seeing, you dismiss as a potential thing of the elderly, maybe you miss a diagnosis that could have a good impact on the family. So I think you need to really do the work as you would do with any other patient, even if the patient is in the elderly. And I would, of course, consider mimickers like amyloid. If a patient has like very high, BNP, recurrent heart failure exacerbation, the blood pressure is not that high, has this thickening, I think that's a patient that would activate evaluation for, hypertrophic/infiltrative cardiomyopathy to try to get to the bottom of it and have an impact in their quality of life. If it's, we don't have an impact in mortality, and then impact, of course, in the family members.
Yeah.
Sometimes it's quite difficult, of course, to like really get some type of differentiation between, is this truly hypertrophic cardiomyopathy or not? That's why we can actually help you, as you do often send the patient to us so we can discuss those patients in our multidisciplinary teams discussions.
Awesome. Thank you very much. From Danny Sims, Aldo, fantastic talk. Thank you. Question, what do you recommend for patients for the anginal component when chest pain is the main concern, or for dyspnea that is due to diastolic heart failure in absence of chest pain or obstruction?
Yeah. So those are, I mean, of course, the treatment definitely needs to be individualized. And that's why it can be quite challenging. So, I mean, if you get a patient that is not the same type of patient, I'm going to start with the second first, because it's a little more nuanced. So if the patient has symptoms of diastolic heart failure and dyspnea, you think the primary driver is that, I mean, you're going to need to de-risk. So if that patient has LVOT obstruction, that's when it becomes a little challenging. We know that, or we have been taught, or we have been told that never use diuretics in patients with obstructive hypertrophic cardiomyopathy. The reality is that, a patient with obstruction can also have diastolic dysfunction. So in the beauty of the current era is that now we can separate the management of LVOT obstruction from the management of, let's say, diastolic dysfunction. So, I mean, if a patient has symptoms of diastolic dysfunction and the patient has LVOT obstruction, I would start, of course, managing first the LVOT obstruction. And if the meets criteria, I start with, myosin, cardiac inhibitors. We know that from data that, by relieving the LVOT obstruction, you're going to have very beneficial changes in your diastolic parameters of cardiac stress and cardiac injury. And that might be it. And that might be all what you need. But if the patient continues to have component of diastolic dysfunction because of the mechanisms that we discussed, well, I think that patient you're going to need to handle as you would with any other one with HFpEF, with just kind of SGLT2, diuresis. The SGLT2 data is promising. We're hoping to get more robust data, but I tend to use a lot of SGLT2 in these patients for many reasons, not only for the little bit of weaker diuretic effect that they can have, but also for the shift in the metabolism that they can do. And we already have some novel therapies that have been tested with positive results in the non-obstructive group. So I think, if I have a crystal ball, I would think that there's going to be something that is going to be positive in this patient population as well.
Thank you very much. Yeah, go ahead.
Yeah, and if you have in the ischemia part, I think that, if the patient has, microvascular angina and there's nothing else, maybe LVOT obstruction or maybe none, sometimes beta blockers you can use, to try to kind of decrease of course, the cardiac demand and just try to minimize that. If the patient have hypertensive heart disease, and you maybe want to combine and the EF is okay and there's no contraindication with calcium channel blockers, I might just choose kind of something like verapamil or something to kind of hit the blood pressure and try to kind of also kind of decrease the demand and try to solve that. But that's sometimes it has to be very, very individualized to the patient in front of you.
Thank you very much. One last question as we're running out of time from Raul. I think it's a very good question, and you showed us a little bit of the AI, software you're using. He asked, his question is about the process of implementing that. How was it, or any tips or any recommendations you can have, technical, statistical, or IRB issues?
Yeah, so I mean, on the AI perspective, I think, I mean, the biggest hassle that you can have to implement some of these tools is just getting the agreement. It's more of a legal hassle. Once you get through that and you get an agreement between the hospital and whatever company or outsourcing provider for the AI, if it's something that is outside, then that is smooth, because some of these things can be integrated very easily. What they do usually is they get connected to the servers that collect some of these imaging techniques, and they just pull the information into the cloud. And those clouds are kind of HIPAA compliant and everything. So they analyze it and then provide an output and then delete the data. So I think, to kind of actually implement it, I think the actual implementation is very easy. It actually took like 2 days to get together the IT department, the Muse department from here to the people that are implementing and making sure that those two servers actually talk to each other. That's it. I mean, the harder part is first that legal part. And the other hard part is how you can communicate and how you interact with the providers, so that way you can, help the patient, but at the same time don't become like a burden to the provider. So we're actually adjusting. So at the beginning, we're like, sending an email to offering. Right now, we're considering saying, hey, we're happy to take care and talk to the patient if you think that is an appropriate referral, so that way we don't put the burden on the provider to call the patient and talk to them.
Thank you very much. Well, this was wonderful. I think we're past the times where we just waited for patients to show to our clinic. I think we're doing more population health, identifying patients that need us, and I think that's the future approach. We have some individual questions about for patients. I would highly encourage you to refer, for patient issues to the hypertrophic cardiomyopathy clinic, where they can be seen at least once and they return to your general cardiology clinic. So again, thank you so much, and I encourage everyone to join next week with Dr. Brownwell, that will be talking about the past, present, and future in HCM. So thank you again, Aldo.
Thank you for the opportunity.
Bye bye.